Hello, I'm Richard Young, your host with Facundo Batista and Kaelan Overholt for MIT's course on COVID-19, SARS-CoV-2, and the pandemic. We've now heard experts discuss the pandemic, the coronavirus, and our immune response to it. When I think about COVID patients, I often think of healthcare providers as the true heroes of the pandemic. These people are helping save the lives of our mothers, fathers, sisters, and brothers. One such hero is speaking to us today. Dr. Victoria Clark is a physician scientist, a person who has both MD and PhD degrees. She is a neurosurgery resident physician at the Massachusetts General Hospital. Her PhD is in neuroscience, and her research focuses on the genetic and epigenetic drivers of meningiomas, the most common primary brain and spine tumor. And for full disclosure, when she's not conducting brain surgery, she spends part of her time in my laboratory at Whitehead seeking to discover new solutions to brain cancer. Victoria, thank you for telling us about the patient.
Well, Rick, thank you so much for having me. It's an absolute honor to be invited to speak again this year. The other lecturers are generals in this war against COVID-19. I'm not a general, I'm a foot soldier, but I love my job. I've already today had the privilege of seeing over 25 patients and seeing them in pre-op as well. And, the truth is, in this country, it's going to be the foot soldiers who take care of you, whose pagers go off at 2 o'clock in the morning, who rush down to the emergency room and take care of you and your loved ones if you get sick enough to end up with COVID-19 and require hospitalization. And it is our honor. And with that, I'd like to talk today about the patients with COVID-19. To start out, so in the medical tradition, we always specifically say we have no financial disclosures or conflicts of interest. This lecture content is not medical advice, so if you have symptoms concerning for COVID, please call your doctor. I will mention specific treatments and specific therapies that are created by pharmaceutical companies, but I'm not affiliated with any company. And then finally, I am a doctor at Mass General Hospital, but my perspectives are my own. So last year, when I was reflecting upon the pandemic, there were really three fundamental concepts in medicine that stood out to me. That is, medicine as a science that, like our compatriots in the biological sciences, like some of the scientists you have heard speak, medicine is a science. We form hypotheses based on direct observation of our patients. We run tests. We analyze the data and try to patch together some clarity and then hopefully a treatment plan. But it's not just a science because especially in situations like our pandemic, there is a paucity of data at the fringes of medicine. There is no clear right answer, oftentimes, of what the best treatment course is. And so that's where the art of medicine comes in, that it's not just a science. It is not 100% data-driven at the edges, but there requires a certain finesse that comes with years of experience. And then finally, the humility to recognize that medicine is a practice that we must and continue to improve, that especially at the beginning of the pandemic, there were clear disparities in outcomes on a hospital by hospital basis. And that a lot of that has in fact been streamlined, fortunately, as formal guidelines have come out from, for example, the Infectious Disease Society of America. There are formal treatment guidelines now available from the NIH. But we must recognize that we have to continue to push this boundary forward, that medicine is a practice. But in the last year, there's really a fourth fundamental concept that, at least for me, has really been highlighted. And that is the humanity of medicine. So on the right here, you can see the graph. This is rates of COVID, in this case, deaths by vaccination status. The black line, this is unvaccinated patients. You can see compared to the fully vaccinated patients in blue, there is an 11.3 times greater risk of dying from COVID-19. This is not a complicated graph. A child can understand this graph, but the point is graphs have never changed human behavior. They do not convince people to stop smoking. They do not convince people to take their heart medications. And it's because our patients are not robots. They are not simply data-driven, rational human beings. There's a lot of fear of the unknown. There is distrust of the medical system and or pharmaceutical companies, in part based on historical inequities, in part due to exposure to widespread misinformation. And there's also a lack of equitable access. And these in combinations all lead to very unnecessary deaths. And the reality is, there are right now in our country, 95 million people over age 12, meaning they are eligible for vaccination, who are not fully vaccinated. And this all comes down to the fact that our patients are not robots. They do have fears. We have to address them on a personal basis, especially as physicians. But our healthcare workers are not robots either. If you're paying attention to the news, there are over 24,000 nurses out on Kaiser and the West Coast who have authorized a strike. I'm not endorsing a healthcare strike. It's not something that I would personally ever do, but I do think it shows how our healthcare system has been stretching and straining to the point of cracking now for over a year and a half. Over 48% of physicians report burnout, with 61% of healthcare workers reporting concern for exposing their families to COVID. And the rate of suicide in physicians is over twice that of the general population. It is an extremely stressful profession. And sadly, there's overlap between the healthcare providers and the patients. The Guardian on their frontline project tallied up to their best ability every single death in the first 1 year of the pandemic. And it was over 36,000, with 32% of those nurses who do spend the most time on a per patient basis, face to face. But it hasn't been all bad. It continues to be an incredible privilege and joy to take care of patients, to support them through these difficult times. And when the vaccine became available last December, there was this wave of optimism, of the sense that the tides were going to change, of hopefulness that we had not felt really since those first cases started rolling in spring 2020. And that's why this year, reflecting on the humanity of medicine, unlike the other lectures, which have sort of provided this very zoomed out view, tackling very important questions like viral replication and the inequities as countries vie for vaccines. Today, I'm going to take a different approach and zoom way in. I'm going to focus on individual clinical vignettes. These are all true stories. These are all the true struggles of real patients who had COVID-19. It's all HIPAA compliance, but they're all true. It's a mix of patients I've taken care of and also some case reports from the literature. And with that, I'd like to start with some case reports in adults. So our first case description is of a 47-year-old man who had severe COVID-19. So this gentleman was unvaccinated, more or less healthy, showed up to Mass General Hospital with a few days of fever and a sensation of shortness of breath, but he decompensated almost immediately, requiring intubation on the first day of hospitalization and was found to be positive for COVID. These x-rays are not from our patient, but I do think nicely show the expected evolution of x-ray changes in patients who develop severe COVID-19. So on the left, here the lung spaces are black. That reflects normal aeration, that's air in the lungs. But on the bottom, on both sides, you can see it's white. That's reflective of bilateral lower lobe infiltrates or pneumonia. Now, this is not diagnostic for COVID-19, but it is consistent with COVID-19. Over the next few days, this patient had increasing opacities until finally the lungs were basically totally white. Bilateral, meaning both lungs, diffuse, meaning all the lobes of each lung, alveolar opacities, and also at this point requiring a breathing tube. This would be consistent with ARDS, or acute respiratory distress syndrome, which I liken to drowning on dry land. You really cannot talk about severe COVID without spending a good time talking about ARDS. Now, it is not specific to COVID or to viral pneumonias. In fact, there are over 60 known inciting causes. For example, a large trauma can lead to this hyperinflammatory response. The early stage is characterized by breakdown of the barriers of the alveoli and the blood vessels, which results in a flooding of the alveoli, the small lung sacs. And then later on, the lungs begin to heal and resorb this fluid with some fibrosis left over. There are multiple cytokines that mediate this process, including IL-6. Unfortunately, the mortality is very high, and it fits into what Dr. Pillai discussed, which is our understanding of COVID-19 in its most severe forms as sort of a two-peaked course, where the first peak is the body's reaction to the direct viral injury. The body's fighting off the virus. And most people get better, but a subset of people launch into an inappropriate hyperinflammatory immune response after exposure to the virus. And it's actually this hyperinflammatory response that leads to death, that leads to this severe COVID-19 syndrome, including ARDS, as well as failures of other organ systems. Even though we've had a pretty good idea of ARDS as a disease process for 50 years, there is no specific medicine that's curative. This is a complicated algorithm showing how to progress the treatment based on ARDS severity. It can include, for example, lying the patient prone in order to improve the oxygenation. But the big picture is the goal is just to provide supportive care to minimize additional lung injury, optimize the oxygenation of the dry alveoli, and then more or less ride it out through the exudative phase and let the patient heal themselves. It's important to mention because it is the most common cause of death in COVID-19 patients. In this study of critically ill COVID-19 patients, of the patients who died, 92% of them had respiratory failure. And once they were intubated, they stayed intubated for a long time, regardless of whether or not they ultimately recovered, on average 11 days mechanically ventilated, which is relevant if you think back to last spring when there was, spring 2020, that is, where there was all this concern about flattening the curve. This is what they're referring to. If COVID-19 patients are spending 11 days mechanically ventilated, our healthcare system was at a very high risk of people needing to come on the ventilators at a higher rate, and they are able to be weaned off effectively, which would trigger and require rationing healthcare. Currently, the NIH COVID-19 treatment guidelines for our patients would recommend for a patient sick enough to be mechanically ventilated, as he is, to receive dexamethasone plus IV tocilizumab. In terms of the evidence behind these treatments, the best evidence for both really comes from the Recovery Collaborative Group. The recovery trial for dexamethasone reported in 2020 that in a subset of patients who received dexamethasone, which is a steroid, the job of steroids is to tamp down the immune system. If you broke it down by subgroups, the patients who were sick enough to require mechanical ventilation really had the most improvement in survival, a difference of 29% versus 41%. Patients who were sick enough to require some oxygen also improved. But there's a non-significant trend for people who were early in the course and were not sick enough to require oxygen, that they actually did worse. And this makes sense because if you think about it, the people who would potentially benefit from having their immune system tamped down by a steroid are those who are in the process of mounting this hyperinflammatory response. But earlier on, they need their immune system to fight back the viral infection directly. Tocilizumab is a monoclonal antibody against the IL-6 receptor. As you recall, IL-6 is, amongst other things, one of the cytokines that mediates ARDS. And it's used for treating autoimmune diseases, including rheumatoid arthritis. The recovery group published this year that the trick for tocilizumab to have effect, because there have been multiple other trials which did not show a strong survival benefit to tocilizumab, that it's really the patients who receive this early, so within 24 hours, early after they begin to require oxygen, and also have laboratory evidence of inflammation. These patients had improved survival and were less likely to progress to mechanical ventilation or death. And there was an emergency use authorization for tocilizumab in June of this year for patients who more or less met this criteria. So similar to Decadron, is this narrow, maybe a narrower group within the first 24 hours of launching the hyperinflammatory response. Tocilizumab does show benefit and is currently considered to be the standard of care. So back to our patients. So he had a very complex clinical course. At the top, you can see hospital day. And then here are medications that are grouped together by what they do. So initially he was requiring paralyzation, which is one of the treatments on that algorithm for ARDS. He's on multiple sedating agents. And at one point required 3 different very powerful medications, which can only be given in the ICU, called vasopressors, in order to maintain his blood pressure at a normal level. This is consistent with shock. So after about a month, his lung mechanics began to improve. He began to breathe better, began to breathe on his own, was no longer requiring, for example, paralysis and sedation. However, he was not waking up. On the bottom, you can see he remains in a vegetative state. The studies that were done at this time were normal. The MRI was more or less normal, non-specific. He had EEG studies. He was not having seizures. And then eventually on hospital day 61, he woke up and began to follow commands. So I wanted to use this case to show how long these patients can stay hospitalized, how really sick they are, the type of heroic efforts it requires on their doctors, nurses, and respiratory therapists to keep them alive. And then also how there's still a great degree of mystery on the clinical course, even after the lung mechanics have improved. Our next case study is a 68-year-old, actually male physician from the rural South, had a history of hypertension, mild coronary artery disease, and a lifelong smoking history. So this was back in September 2020. He started out with what he thought were allergies, not unusual for September in the South, but developed a cough on the 3rd day and a very low-grade temperature. He underwent nasopharyngeal COVID-19 PCR. The results took about 30 hours to come back, and he was found to be positive. So for this patient, let's think, what are the risk factors that make him at high risk for severe COVID-19 and death? And are there any treatments available that minimize his risk of COVID-19 progression? What is very clear and has really been clear from the beginning is that age is a major risk factor for severe COVID-19 and death. Here I've broken down the COVIDNet data by age, and you can see with each decade, there is a clear increased risk for severe COVID-19 and death. In the case of our patient, compared to the control group of age 18 to 29, he's actually at a 90 times higher rate of death. And if you think that's bad, consider that someone 85 and older is at a 570 times increased risk of death compared to the control group. I am not aware of any other disease process which so profoundly has this age correlation, especially in patients over 85 years old, is quite profound. Now, our patient is Caucasian, But I would be remiss to not bring up in terms of risk factors that it's clear that racial and ethnic minority groups are at increased risk for COVID-19 hospitalization and deaths, but that this is not attributed to underlying, for example, genetic differences that tend to run in different racial and ethnic minority groups, but rather serves as a risk marker for other underlying conditions, for example, socioeconomic status, access to healthcare, and the types of jobs. These, in some cases, related to socioeconomic status, these are not everyone works remotely. There are some people who are required to continue to go and work front line one way or another. And that the thought is that the differences and these social and economic statuses do account for the majority of the differences in hospitalizations and deaths. So for this study, which again looked at the patients who were sick enough to get admitted to the ICU in the United States, what did they actually die of, and what were those risk factors? And they found that the major risk factors associated with death include advancing age, being male, BMI, and several other factors, including being admitted to a hospital with fewer ICU beds. So if the same hospital had taken this patient, if an ambulance had taken this same patient to a hospital with over 100 ICU beds to one with less than 50 ICU beds, the rate of dying was over 3 times higher for being taken to the smaller hospital. So in terms of risk factors, we said age, that he's male, these underlying heart condition, hypertension, smoking history, and that he's from a rural area with very few ICU beds. And at the time of September 2020, treatments that had received emergency use authorization from the FDA for non-hospitalized patients were none. So the plan for this patient would be to ride it out and see if he got worse enough to require hospitalization or see if he recovered on his own. Now, I did tell you all of these stories are true vignettes. There's one detail I left out, which is that this actually happened in September 2021 and not 2020. So all of his risk factors were the same, but a major difference is that as a physician, he had early access to vaccination, and he had been fully vaccinated as of January 2021. Other changes, instead of undergoing nasopharyngeal PCR, he took a home COVID test as soon as he developed significant symptoms. The test cost $12. He had results within 15 minutes. And that very day, he drove down the road and was able to receive a monoclonal antibody cocktail infusion for free from a local hospital. The next day, he did develop a fever to 101.4, but he was able to reduce it with over-the-counter medications. By day 6, his symptoms resolved. He completed the CDC recommended quarantine and ultimately returned to work without additional issues. I think this vignette really demonstrates how far we've come in the past year and how much better we are at treating patients like this who are at very high risk of developing severe COVID and of dying. And in this case, our patient had a very mild course and recovered completely. But this is considered to be a breakthrough infection because breakthrough infection in vaccinated patients. On the left, you can see a similar graph to what I showed before, the peak of unvaccinated patients compared to those with any of the 3 vaccines that are approved in the United States. And really, all of them provide very good protection against being tested positive or of dying. On the right, I'm showing the different genotypes of the variants that were running rampant in the United States in August. And you can see in August, really well over 95% of the variants and cases were the Delta variant, which is in orange. So even though these vaccines are not specific to that genetic variant, they are still providing excellent coverage. For the antibody cocktail he received, there are multiple antibodies that have received EUA from the FDA. In this case, he happened to receive the Regeneron-CoV-2, which is a combination of 2 monoclonal antibodies against the spike receptor binding domain. This EUA was granted in November of last year for non-hospitalized patients, but for those who are at high risk of progressing to severe COVID. The study, which they published in the New England Journal of Medicine, showed that it's really the patients who have the highest viral load, so greater than 10 to the 7th copy. These are the ones where there's the greatest reduction in viral load compared to placebo at 7 days. Ultimately, in this case, a 2 log reduction in viral load, very significant. The thought being that, an antiviral, this cocktail is intending to fight the primary viral infection. So the group that's going to benefit would be that early on in the course, while the active viral infection is the main issue, and the hope that it would prevent this immune hyper response. But if you give it later, when the main issue is the hyperimmune response, sort of the horse is out of the barn, it's not predicted that there would be great benefit from this antibody. Our third case study is a 28-year-old female with long COVID. So she was unvaccinated, previously healthy, was found to be COVID positive with very mild symptoms. Quarantined at home, never required going to the doctor or being hospitalized. But over the next month, she reported extreme fatigue, elevated heart rate, a sensation of brain fog. And for these symptoms, not for the initial COVID-19 infection, she presented to the emergency room twice. The studies were normal, other than she did in fact have an elevated heartbeat. And so no one could really figure out what was going on with her, which is very frustrating to her. Her symptoms were severe enough that she quit her job. She's essentially bedbound, but serial pulmonary studies were normal. Her symptoms were attributed likely to bronchial inflammation. She was seen for her musculoskeletal symptoms. She reported numbness, poor memory, challenges with concentration, and these symptoms persisted. Her physicians, it was a multidisciplinary team, decided to treat the symptoms individually, giving medications to slow the elevated heart rate, giving a steroid inhaler to help open up her lungs a bit. And then very slowly, she was able to begin advancing her activity back. So long COVID, truth be told, is still an area of very active study and evolving understanding. It's also known as post-acute COVID-19 syndrome. The definition is it's experienced 4 or more weeks after infection. It doesn't require severe infection, can occur after mild or asymptomatic infection. And the symptoms, like our patients, are quite non-specific, but what is frequently reported is this sensation of brain fog, fatigue, malaise, fast heart, and shortness of breath. Now, I want to be very clear that long COVID or a chronic fatigue syndrome after an infection is not unique to COVID. That after other viral infections, for example, Epstein-Barr virus and Ebola, have had similar symptoms afterwards. And there is a disease process that's similar, poorly understood, called encephalomyelitis chronic fatigue syndrome, which overlaps with some of these symptoms. In terms of the graphical representation, so the idea is, after about 4 weeks, some people still do have lingering positivity of PCR. So these people are thought to have sort of ongoing direct COVID in a subacute way. And then another group is no longer PCR positive, but they are having these chronic or post-COVID-19 symptoms, including those that our patients had, the palpitations, sometimes kidney damage, hair loss, and an overall sense of fatigue and brain fog. There's no cure for this. We're still trying to figure it out. But generally, the care is multidisciplinary. There are COVID-19 clinics. Actually, one of the later lectures is called the COVID-19 clinic. So I suspect the multidisciplinary care that these patients receive will be discussed in depth there. But overall, the idea is to support the individual symptoms while we continue to try to figure out the underlying etiology. Next, I'd like to focus on COVID manifestations in children. As you can imagine, if a 17-year-old gets a viral infection, it can be very different from if a 10-year-old or if a 10-month-old gets the same infection. When I was in medical school, one thing they really enforced over and over to us, and I think of it as a central mantra of pediatrics, is that children are not just small adults. You cannot just weight-based dose, the same medications and expect for a similar response. Children and adults can be infected by the same virus and have a very different manifestation. And this is in part because their immune system is developing and the organs that process medications, such as liver and their kidneys, are developing. And there is the potential for a disease process and or the treatment to have long-term developmental implications. Overall, children do very well compared to adults, with the 0 to 4-year-old children do requiring hospitalization at a higher rate than older children, but overall, much better outcomes compared to adults. And this large study looked at, for 12,000 COVID-19 positive American children, the rate of hospitalization was about 5%. Of those who do get hospitalized, about 17% required ICU admission and 4% were ultimately intubated. But despite this very large study of 12,000 children, there were less than 10 deaths recorded, which is very different from the COVID studies that are done in adults. This case report is a 6-year-old female who had Miss C. So it is a 6-year-old healthy girl. She was exposed to COVID-19 from one of her caregivers, her grandfather. 2 weeks later, she had very high fevers, headaches, vomiting, diarrhea and abdominal pain, and a rash, causing her to go to the emergency room. At the time of evaluation, she was breathing very fast, 24 times a minute, and her heart rate was 138. She decompensated very rapidly. Within 2 hours of hitting the ED, she was intubated for respiratory failure, had very low blood pressure requiring pressor support. Her lab values showed systemic inflammation, as well as a positive SARS-CoV-2 IgG antibody. Fortunately, despite how sick she was, she recovered. She received broad spectrum antibiotics, other medications to tamp down the immune response, such as steroids, IVIG, and tocilizumab. And she was ultimately extubated on the 9th day of hospitalization and then discharged on the 14th. So Miss C, which is the multi-system inflammatory syndrome in children, is distinct from the adult hyperinflammation, this double peak that we've discussed, because the children can have extremely mild or no COVID symptoms, completely recover, and then about 3 weeks later have these systemic symptoms, which is very different from the adult, which is more of a progressive worsening without this period of improvement in the middle. The symptoms in children, you can see this is a picture of a small child on the right who has a characteristic rash, primarily affect multiple organ systems, including the heart in 80% of the time and the gastrointestinal system most frequently, similar to our patient who had abdominal pain and diarrhea. There is another condition that's seen in a post-infectious state in children called Kawasaki disease. Miss C does have overlapping features, but is also distinct. And although these patients are very sick with 4 or more organ systems involved and requiring ICU level care, fortunately, mortality is very low. Finally, I would like to focus on a case report on a very vulnerable population of patients, which is the pregnant patient and fetus. So pregnancy is a time of great metabolic change for the pregnant patient. The cardiac output increases 50% in pregnancy. At baseline, pregnant women are at a higher risk of strokes and clots because it's a hypercoagulable state. There are changes in the immune system that allow for the fetus to not be attacked by the mother's immune system, who would recognize the fetus as non-self otherwise. And we already know for other viral infections, for example, cytomegalovirus, that if the pregnant patient is infected, it can be passed through the placenta and affect the fetus with very long-term developmental implications. So on the left, you see a normal brain. On the right, you see an example of congenital CMV infection. This here, the water spaces in the brain, the ventricles are quite enlarged. There's calcifications. This viral infection, which has been passed to the fetus, has very severe developmental implications. And the question has been, Does COVID-19 do this? Can it be passed from the pregnant patient to the fetus? So this is a case study of a 29-year-old previously healthy female who was towards the end of her pregnancy, so 34 weeks, who developed 4 days of fever and shortness of breath, was found to be COVID positive. In 3 days, she rapidly decompensated. So this is a chest CT. On the left, you can see on day 2 versus day 5. By day 5, there's really bilateral whiteness. This is the fluid. This is the ARDS that is occurring in her lungs. And she actually had to have the fetus emergently delivered in an attempt to improve the ability for her lung to move, because the fetus actually compresses the diaphragm and really can limit lung movement in pregnant patients. However, unfortunately, the day after delivery, her lung mechanics continued to worsen. She had already flipped into ARDS and she required intubation. So this is a diagram of her hospitalization course. These are the medications she received, similar to other ones we've discussed. She was intubated, but fortunately was able to be extubated. Ultimately was discharged on the 12th day after her delivery with improvement in her lungs. The baby remained negative for COVID-19 and was healthy. So, as Dr. Walensky mentioned, pregnant patients are a very high-risk group for severe COVID-19, higher risk of needing the ICU, higher risk of mechanical intubation, and higher risk of mortality. And in terms of the impacts on the fetus or neonate, the odds of preterm delivery are much higher. The need for neonatal ICU admission are higher as well. So in terms of vertical transmission, can COVID-19 be passed from the pregnant patient to the fetus? Well, it has been documented. This is a case report of a 35-week pregnant woman hospitalized because she required a C-section. The obstetricians were able to very sterilely sample the amniotic fluid, placenta, and the neonate's blood, and it all tested positive for SARS-CoV-2. Here is the placenta staining positive. An MRI on the neonate demonstrated a white matter injury to the neonate. So it has been documented, but overall it appears to be rare, with a meta-analysis listing about a 3% risk of vertical transmission. Unfortunately, pregnant women have one of the lowest rates of vaccination, of 33% overall, but with marked disparities in vaccination rate by race ethnicity, with African-American patients being vaccinated at a rate of only 17.4%. At this point, 97% of pregnant people who are hospitalized for SARS-CoV-2 infection are unvaccinated. And there have been additional benefits to vaccination, not only for the pregnant patient, but for the neonate, as vaccine-derived antibodies are present in the breast milk, as well as in umbilical cord blood, providing protection. So the CDC does strongly recommend vaccination either before or during pregnancy. So as a summary of the spectrum of COVID-19 patients, vaccination is very protective against hospitalization and death, 11.3-fold, including against the Delta variant. That advancing age and medical comorbidities increase the risk of severe COVID-19 in adults, that children are at a lower risk of severe COVID-19 compared to adults, but can develop the hyperinflammatory condition MIS-C. Pregnant patients are at a high risk for severe COVID-19 and have a low rate of vaccination. And although several treatments have received FDA, EUA, or approval, there remains no cure for COVID-19. Now, the case vignettes, the patient stories I shared with you today, they all survived. But there are over 700,000 cases I could have shared today in the United States alone who did not survive. You know, we have to continue to take this very seriously. This is continues to be the worst strain on our healthcare system and on our patients. We have to continue to wear masks when we're indoors in places where COVID has a high rate, which is essentially everywhere right now. We need to protect the medically vulnerable, and we need to get vaccinated. And with that, I'd like to thank Rick Young for being my mentor and supporter now for 7 years in the Young Lab, MGH Neurosurgery, especially my chair, Dr. Carter, MGH, our now past president, Peter Slavin, who really did an incredible job when MGH was at the peak of the pandemic last April, ensuring that we never ran out of ventilators and we never ran out of masks. And again, this pandemic has been extremely unpredictable. We don't know how many more tricks COVID-19 has up its sleeve. So get vaccinated. And with that, I'm happy to answer any questions.
Thank you so much, Victoria. We have a bunch of questions for you. So let me start with vaccination, because that was an important theme. It's clear it's protective against hospitalization and death, but if you become infected and hospitalized, do you generally have a better outcome? For example, are your responses to medications better?
I would say that because COVID-19 breakthrough infections are relatively rare. I have not seen a very high level study that looks at breakthrough infections specifically in terms of response to, for example, dexamethasone. But when we zoom out and look at the big picture, the reality is it is over 11-fold protective against death. The vast majority of patients who are vaccinated do not die. And that typically was the endpoints of the studies that were the clinical trials. The endpoints were really not, can you get infected? It's really, when you get infected, do you develop severe COVID? Do you require hospitalization? Do you die? And I think from that perspective, the data is clear that they have overall very improved outcomes. And then simultaneously, our ability to treat severe COVID, while there is no cure, has improved in the past year. I think one of the major improvements has been, now that there's enough evidence, that societies have released these guidelines similar to the ones that I showed. So my hope is that that levels out some of the disparities that are seen in outcomes from the larger hospitals compared to the smaller hospitals, now that there's sort of a set standardized game plan. Of course, for every patient, they have individual patient factors, and they have to be taken into consideration. It's not a one-size-fits-all plan. But I do think overall, the data is very clear that vaccination, regardless of the vaccination that you've received, is very protective against death.
And how about long COVID? Do we have enough data to know whether or not vaccination suppresses the number of cases of long COVID if there's a breakthrough?
So there have been these sort of reports of patients who self-identify as long haulers, claiming that they feel like getting vaccinated has improved their long COVID symptoms. So I think the jury is still out on why that is, or if that really holds up, or if there's a degree of placebo effect to that, or if it just coincided because maybe their long COVID symptoms would have resolved anyway at 6 months. There is a very large study that is starting now, has been funded by the NIH to really look into long COVID to get to the bottom of it. My personal opinion is it's very reminiscent to me of other autoimmune diseases that I have seen that have happened post-virally. So for example, in neurology and neurosurgery, we see a condition called ADEM, where after a patient has been exposed to a viral infection, they can develop autoantibodies against myelin in the brain, and they suffer neurologic devastation for that. So whether or not long COVID is in fact autoimmune, I think is still up in the air. I know that is a hypothesis which is being tested, though by definition, if you never get COVID to begin with because you're vaccinated, then you will never get long COVID either.
Yeah. And one more question along these lines. given that COVID's going to be around for some time, how does recovery after hospitalization and therapy compare to other diseases such as flu or RSV?
So I think one thing that's different compared to flu or RSV is how sick on average patients with severe COVID get. So certainly people with influenza can become very sick and require intubation. Same thing for RSV, especially in children. But the length of time that patients are requiring critical care. So I showed that statistic where even the survivors of COVID-19, if they're sick enough to require mechanical ventilation, stay on it for weeks. They're in the intensive care unit for weeks, and then in the hospital after that, and then presumably in a rehab facility in many cases after that. So it's difficult to parse out how much of the challenges, additional challenges to recovery are from direct results from the virus, are tied into this long COVID concept where maybe some people are actually still testing positive at 4 weeks, or who are launching into this other post-acute syndrome. And then how much of that is reflective of the fact that they've been in the hospital for 6 weeks in some cases. And being in the hospital really takes a lot out of you. Not only do you tend to be in bed all the time, it's very deliriogenic. So it's very common for older people, even older healthy people, to become very delirious in the hospital. There's a loss of a sense of day and night. So I would say if you put a healthy person in the hospital for 6 weeks, I think that they could require some recovery. And then it's not good for the brain to be intubated and under sedation for weeks and weeks. It's just not good for the brain to be under anesthesia for that long. So I think that's another component, especially for patients who are hospitalized and have severe COVID, that does require a longer time scale for recovery.
Let's talk for a minute about the diversity of symptoms you described. And I'm so struck by this remarkable diversity. And I've assumed that an underlying component is everyone's genetics is a little different. And so the way that each individual responds can be a little different. But it makes me wonder, as a physician, how do you separate symptoms you see that may not be associated with an infection by SARS-CoV-2? You've got some evidence that there is an infection from say a PCR test, but you have in some patients symptoms that are atypical. How do you separate those? How do you look at that as a clinician?
Honestly, that's what makes medicine fun. That's what makes it a challenge, is that no two patients are the same. Everyone is different. Everybody has their own predispositions. Sometimes you don't even know what some of them are until you do a UTOX. But that's what makes it exciting. That's why it's wonderful to have an individual relationship as a physician with the patient, because it is a riddle. It's a challenge. You have to figure out, when you're seeing what we call in medicine like a zebra, someone who doesn't have the symptoms that you would most closely associate with what their presumed, underlying diagnosis is. Is it really something totally different? Or is this a new manifestation of the same process? Or do they have some other completely separate process going on that no one has ever diagnosed before, and it's being unmasked by a COVID infection? So that is definitely where the art of medicine and where the practice of medicine come into play, is having that insight. Especially I've seen more senior clinicians who have 20 years of experience say, the labs are all normal, but this is just not consistent with the other patients I've seen in my 20 years of experience. And I think that we should broaden our search. And that's how we continue to make new discoveries on an individual patient basis.
I remember last year you telling us that one of the features of pandemics is classically that there's a wave of depression, of damage to society that is not directly due to the virus, but is an outcome of all the secondary effects of a pandemic. And I was struck by you saying that one of those features that I didn't anticipate is the extent of physician burnout, the challenge, you know, in terms of depression and suicide among healthcare workers. How is your institution adopted to these things over the last year? What are there procedures that MGH has put into place to help physicians and other healthcare providers?
I think it's extremely important to talk about these issues. It's something that I think, you know, historically medicine, especially neurosurgery, has been very stiff upper lip. You know, you're not the patient, you're the doctor. But I think that as a society overall, we're beginning to realize that our doctors are not robots, our nurses are not robots, that it's really challenging to take care of people who die all the time. It's really challenging to talk to their families about it. I think MGH has done a very good job. You know, we have seminars about mental health here. We have, you know, sometimes it's just the little things. They've actually done a good job sort of like putting up little signs, you know, to the healthcare workers that basically more or less say, keep going, you're doing a good job. And I think it's not even so much what the individual things are, it's more that people are talking about it. I know some of my friends who are in other parts of residency have reported like a high rate of PTSD from being in the COVID ICUs last April and doing all those intubations and seeing all of those terrible outcomes. And their residency program has been very open to that. They have made sure that they're available to have mental health counseling. And I do want to point out something about burnout. You know, burnout is way worse than being exhausted. Like I'm exhausted sometimes, but I'm not burnt out. I still find great value in my work. I still love taking care of my patients. I still feel empathy for them. But the problem with true burnout is those are the things that get lost. It's way beyond just feeling exhausted. It's the loss of value in what you do. And I really think that overall the rate of that is increasing because of COVID. And it's something that we as a medical profession really need to do a good job looking out for each other.
Well, Victoria, you're an inspiration to me. Thank you so much for all that you do. And thanks for giving this lecture today.
Thank you so much for having me.